Thanks, Dr. Hartley. Good morning, everybody. Well, it is an exciting time in obesity. As you guys all know, that's true in the adult world, and it's true now in the pediatric world, which is super exciting, because for a long time, we would give lectures about how to treat pediatric obesity, and there wasn't a whole lot we could say, and that has absolutely changed in the last 3 or 4 years. So we'll talk about that today in detail. I did not get through all my slides yesterday giving this talk, so I'm going to try to be more concise today. But I also, on the other hand, I want to encourage you guys to ask questions and interact. That really is my favorite part of giving any talk, is the interaction. And I don't have an agenda with this. I have my slides, but really I want to talk about what you guys want to talk about. And so just encourage you to, at any point in the talk, raise your hand and ask a question. So let me see if I can figure out how to advance here. So our learning objectives: know the benefits and adverse effects of the new anti-obesity medication options in pediatrics. And number 2, know the referral criteria, benefits, and adverse effects of pediatric bariatric surgery. So we'll start with some definitions. This is, I'm sure, review for you guys, but we define obesity as your BMI, body mass index, and BMI is a calculation that uses both your weight and your height. And that is not a great definition of obesity. We're going to talk about that a little bit more in the next slide, but it's kind of the best that we've been able to come up with. So we define overweight as a BMI between the 85th and 95th percentile, and in pediatrics, of course, this is anchored to your age and sex, and the appropriate BMI for an 8-year-old is very different than the appropriate BMI for a 12-year-old or a 16-year-old, and so it's very important to anchor that, and you guys have all looked at the pediatric growth curves and have a sense of that. We define obesity as a BMI above the 95th percentile, and more, especially in the research world, we're using class of obesity, so class 1, class 2, class 3, which refers to further kind of elevations in the degree of obesity. And those are defined as a percent of the 95th percentile. And I think clinically that's a little clunky to say it like that, and I never did explain it to parents that way, and I wouldn't encourage you to. But in the research world, it just adds a level of precision to the calculation that's necessary for the statistics. In the adult world, you'll see the same thing: class 1, class 2, class 3. That corresponds to class 3 is a BMI above the 40th. I'm sorry, a BMI above 40. Class 2 is a BMI above 35, and class 1 a BMI above 30. And in the adult world, those degrees of BMI elevation really do predict more morbidity and mortality, so they are useful. All right, so kind of some criticisms of BMI as the way to define obesity. So it is a weight-based definition. Of course, height's in there too, but height's just there to anchor the weight. You know, the appropriate weight for somebody who's 6'2" is different than somebody who's 4'10", right? That's intuitive. So it's a weight-based definition. It is not a health-based definition. And there is an association, there is a relationship between BMI and health, but it is not a one-to-one relationship. So you can have somebody that has a BMI that is in the normal range, and yet they are metabolically unhealthy based on how they carry that weight, where that weight is, how much visceral fat it is versus subcutaneous. And conversely, you can have somebody who has a BMI that's in the obese range, and they are metabolically healthy. So think of somebody that has a lot of muscle mass and not a lot of fat mass. They can have enough muscle mass to put the BMI in the obese range, and yet they're not metabolically unhealthy. So to define obesity based on your BMI leaves a lot to be desired, and you have to really think through the individual patient. The real question is, are they metabolically healthy or not? So everybody criticizes BMI, and rightfully so. Nobody really defends BMI as the perfect definition of obesity. But the problem is nobody has a better alternative, at least not one that is not invasive or expensive or hard to do. BMI is just so easy because height and weight are so ubiquitous that we can readily define it for most people. So I think it's the BMI-based definition is helpful on a population level in terms of prediction of risk from heart disease and all-cause mortality and so on. But on an individual level, it can absolutely be misleading. And you have to know the patient in front of you in terms of a whole lot more than just their BMI to really assess their metabolic health. So the two things that BMI, the shortcomings on an individual level, it's not going to take into account differences in muscle mass versus adipose tissue. So think of a middle linebacker in the NFL. He's got a BMI that's in the obese range, but he does not have a lot of fat. He's got a lot of muscle, and it says nothing about his metabolic health. And then the second thing that maybe is a little bit more subtle, but there are differences in how we store fat. So the same person, or not the same person, but two different people can have the same amount of body fat. One person stores it more as subcutaneous fat, the other person stores it more as visceral fat, and the person with more visceral fat is going to be more metabolically unhealthy. Some people just genetically are able to, it's probably a double-edged sword, but you're able to store fat in the subcutaneous space and not have it spill over into the visceral fat space, which is more in the belly area. And those people may be more prone to gain weight, but it's not necessarily an unhealthy weight. And then there's some people kind of on the opposite side of the spectrum where as they start to gain weight at all, and some of these people have a very thin habitus, I'm like this, is that if I gain weight, it's visceral fat, and it's very unhealthy metabolically. So you have this kind of phenotype of somebody who's thin, but more the belly, in that very much shows up in the labs as high triglycerides, low HDL, high insulin resistance, high risk of type 2 diabetes, and so on. So those are some things that BMI just does not is not able to drill down to from a nuanced standpoint. So what we really mean by obesity is not that somebody's BMI is high or that their weight is high, but that they have an increase in unhealthy adiposity. And that's how I really want you to think about obesity, not so much BMI. The problem with that, of course, is that it's super hard to quantify. If we had a measure where we could objectively say, here's your number for your unhealthy adiposity, we would use that. And a lot of the criticisms of BMI would just go away. But we don't have that. People have suggested, DEXA scans or MRIs, or, there's all these kind of more expensive things we could do to get at this idea better than a BMI, but they're all expensive and not really appropriate on a population level. So hopefully I wanted to spend a little bit of time on that, but I think there's just out in the lay press a lot of confusion about BMI, a lot of criticism that is, appropriate, but also kind of nobody really nobody defends BMI from that standpoint, and we have to have a little bit more of a nuanced understanding of what obesity and unhealthy adiposity really is. So before I go on to the next slide, any questions on that, or are we tracking okay? This is trends in obesity. This is review for you guys. We all know that the rates of obesity in both adults and pediatrics have really skyrocketed over the past 3 or 4 decades. So I think this brings us to our first question. Let me read this for you. Longitudinal population studies show that BMI during adolescence has the following impact on mortality rate in adulthood. A, obesity during adolescence predicts increased mortality in adulthood. B, obesity during adolescence has no impact on mortality in adulthood. C, obesity during adolescence predicts decreased mortality in adulthood. And lastly, D, it's not BMI, but how the increased adipose tissue is distributed that predicts increased mortality in adulthood. And I'll tell you before I go on to the next slide where you can vote, I did not write this question very well. I'll give you a hint on the answer. It's not D, only because I think it probably is D. The reason it's not D is we don't have the data. So we don't have long-term longitudinal studies that look at what I'm saying there in D at baseline, if that makes sense. So if we did have those data, I have no doubt that that would be highly predictive and better than BMI, but that just simply doesn't exist. So with that little hint, let's see, I think you can vote now. I gave the question away, so I won't belabor this too much. So it's A, and if you answered D, you know we're on the same page, but the true answer is A. And there are some really well-known long-term, like national cohorts, especially in socialized countries in Europe and most famously in Israel. In Israel, they have obligatory military service, like at 18, 19 years old. So everybody gets a physical exam, and then they have socialized medicine, so they follow that out over time. And so they've been able to publish these huge databases over 30 or 40 years. And it very well shows your BMI when you're 18 years old predicts increased, whether it's all-cause mortality, mortality from heart disease, mortality from type 2 diabetes, on and on. Your BMI at 18 is predictive of mortality, however you want to look at it. All right, good job, leaderboard. Is there a prize, John, for who answers the most questions? Psychological prize. Psychological, yeah. All right, so you guys may know the AAP came out with guidelines a year ago on obesity, and this is a big deal. This had a lot of press, a lot of feelings engendered on this, positive and negative. These are huge undertakings. You can see the list of authors here. It's enormous, and to be able to assimilate all the most recent data into one document is just an impressive task. But the way these work, and I've been able to talk to some of the people that co-authored these guidelines, they had to, new data is coming out all the time, right? And if you're going to write guidelines, at some point you have to say, okay, we're just going to stop taking in new data, and we're going to have some point where say, okay, no more new data, we're going to write this, we're going to publish it. And even once you stop that point, it was still like a 2 or 3 year process after that they wrote this. So I think they had to cut off any new data like in 2019 or something like that, and then that was just published a year ago. So they actually did that before any of the new phase 3 trials that showed that the new anti-obesity pharmacotherapy. None of those details are in the guidelines. We're going to go over those details in the talk today, and we're going to review those phase 3 trials that led to the FDA approval of the 3 new pharmacotherapy options that we have in kids. But as far as the guidelines, they are more of a, I don't say this negatively, but it's more of an opinion piece as opposed to kind of like a practical, here's how you do it, nuts and bolts piece. But from that opinion part, they really did try to move the needle in terms of being more aggressive with more than just lifestyle therapy in obesity, right or wrong. And that got a lot of pushback from a lot of people. And I'm not here to tell you what the right answer is, but they really tried to move the needle in terms of, okay, it's no more just kind of lifestyle therapy. We should be more aggressive. So I'm going to just share some quotes from the guidelines, and then we'll get into the nitty-gritty and practical stuff. But so these are a couple quotes. There is no evidence to support either watchful waiting or unnecessary delay of appropriate treatment of children with obesity. And furthermore, this clinical practice guideline recommends early evaluation and treatment at the highest intensity level that is appropriate and available. So they're saying, it's for sure do lifestyle, but it's appropriate to, as soon as you can, go to a higher level of therapy. A lot of, I think, the motivation behind that is in this push with the insurance companies to get these therapies paid for. And that is kind of the huge caveat of a lot of what I'm going to talk about today, is that these are now FDA approved, the medications, but by and large, insurance companies are not paying for them. That's to some degree true in the adult world. It's even more true in the pediatric world. So we're just, even at a tertiary care center like Phoenix Children's, where you have a lot of endocrinologists that are trained in this, we did not have much opportunity to actually prescribe these and get them covered by insurance. So some of this, the language they use is it's for that purpose as much as anything else to put pressure on the insurance companies. So another quote from the clinical practice guidelines: pediatricians should offer adolescents aged 12 years and older with obesity, weight loss pharmacotherapy according to medication indications, risks, and benefits as an adjunct to health behavior and lifestyle treatment. And then lastly, pediatricians should offer referral for adolescents aged 13 years and older with severe obesity for evaluation for metabolic and bariatric surgery to local or regional comprehensive multidisciplinary pediatric metabolic and bariatric surgery centers. So there's a lot of people that felt like, hey, we're just kind of pandering to big pharma with these guidelines, and whatever happened to lifestyle, and should we just be putting every kid who's obese, which is close to 20% of the pediatric population, on expensive injections every week? And a lot of people kind of are not comfortable with that, and I definitely understand that sentiment. And then there's kind of another school of thought that, hey, finally we have something that works, and we should absolutely be utilizing these medications that are so effective as much as possible to help kids with their metabolic health. And I think it's both are probably true, and it's I've certainly had a degree of ambivalence with all of this in terms of wanting to be able to utilize medications for the patient, but also feeling I guess my heart of hearts, I want to focus on lifestyle and really not utilize the medications or bariatric surgery if I don't have to. So let's move on to the more practical side of this. There's three kind of buckets of treatment for obesity. So lifestyle therapy, medication, and bariatric surgery. And this is kind of taken from the adult world. We don't have these type of data in the pediatric world, but I think they extrapolate pretty well. The general rule of thumb for treatment of obesity, especially if you're talking about randomized controlled trials, is that lifestyle can get you about a 3 to 5% decrease in body weight compared to baseline and compared to placebo. And that's over, randomized controlled trials that are maybe over 6 to 12 months. Secondly, as you go down that column, medications, and this, I'll speak before the advent of the GLP-1s first, but then we'll include the GLP-1s. But before the advent of the GLP-1s, the rule of thumb was medications could get you about 5 to 10% decrease in body weight compared to baseline relative to placebo. With the advent of semaglutide and now tirzepatide, you're talking 15% and maybe even up to 20% with medications, which is really remarkable. So that's medications. And then bariatric surgery, you're talking 25 to 30%. That's true in the adult world. That's true in the pediatric world as well with bariatric surgery. It very much mirrors the effectiveness in adults. So note that as you go down that column, it's increasing cost, it's increasing invasiveness, it's increasing risk for side effects, adverse events, and it's decreasing access. So that's the balance that you walk with these treatment arms. So lifestyle is certainly the safest, but it's also the least effective. And one other comment on this kind of big picture slide. All the advances in the world of obesity treatment, adults and pediatrics, are in the bottom two. It's in medications and bariatric surgery. I absolutely believe in lifestyle therapy, and I would venture to say that nobody in this room can outflank me in terms of focus on lifestyle therapy. So understand that before I say what I'm about to say, but we just simply, from a research standpoint, have not been able to learn anything new that's effective in the lifestyle world, and that's going back decades. So if I was going to give a talk to you on lifestyle therapy 20 years ago, it wouldn't be a whole lot different than what I would say today. There'd be nuances of difference for sure, but from looking at the actual studies that look at randomized controlled trials, we just have not been able to move the needle there a whole lot, unfortunately. I still believe in lifestyle. I still absolutely think it's the right thing to focus on. But if you want to capture it in randomized controlled trials and be evidence-based about it, unfortunately, we just haven't been able to do that. And so I'm not actually going to talk about a whole lot about lifestyle here, but I do want to highlight one thing, which is a study published in JAMA, I think in 2017, from the United States Preventative Services Task Force. We're going to talk about this more in a couple slides, but let's start with a question here. So this review, or the systematic analysis from the USPSTF from a few years ago, looked at a bunch of randomized controlled trials of lifestyle modifications in pediatrics. And they concluded that in order to have a reliable kind of evidence-based decrease in BMI relative to baseline, you needed at least how many contact hours with the patient, with the pediatric patient, to reliably lead to weight loss. So that's the question. We'll advance here. 4 hours, 10 hours, 16 hours, or 26 hours? All right, let's move on. All right, we got a little heterogeneity here in our answers. I like it. So the right answer is D, 26 hours. And I'm going to advance to so this is the JAMA article, 2017. Basically, they found if you had less than 26 contact hours with patients in the pediatric world, there was no evidence base that it would lead to a decrease in BMI. So you had to have at least 26 hours. And furthermore, at 52 hours, the degree of BMI change improved and you were able to affect improvements in metabolic health. So this is kind of a pessimistic view of it, but from 26 hours to 52 hours, modest BMI change, but no cardiometabolic improvement that they could find. You had to get above 52 hours to get the cardiometabolic improvement. And that's a problem, and it's a problem on two different levels. From the institutions that are delivering these therapies, that's hard. That is very hard to deliver a program where you're giving over 26 hours of contact therapy with the patients. It's expensive. You have to have a lot of expertise. It's hard to get that all reimbursed. And that's why simply there are not a lot of programs in the US that do this. The ones that are there are usually funded through research or through philanthropic support. And there's just not a whole lot of them across the country because they're hard to run and they're not economically sustainable. So that's one problem. The second problem is from the patient standpoint. How many of your patients that really struggle with obesity are able to give up at least 26 hours of their life over the next 6 months to drive, twice a week to the tertiary care center, probably, at 5 o'clock in the afternoon in rush hour traffic. And we tried some of these programs at Phoenix Children's over the years, especially early in my career. And I thought we were super excited about some of these programs. And we just had this really unfortunate attrition of patients. We'd have patients sign up and then halfway through, they just would stop coming. And so it's just understandably very hard from a patient standpoint to have the degree of commitment to complete a program like that. So from the institution side, it's hard because it's not economically feasible. From the patient side, it's hard because it's just hard to give up that much time. So that's why there's not a whole lot of programs like this that exist across the country. And unfortunately, that's why lifestyle just has not, especially kind of in the ivory tower, it's, they've kind of wanted to move beyond that and say, okay, let's do the stuff that really works. So that's what we're going to spend the rest of our time talking about is medications and then bariatric surgery. So this is a list of anti-obesity medications in the adult world. And I highlighted here the ones that are FDA approved now in pediatrics. We are not going to talk about orlistat. Orlistat's there more from a historical standpoint. It was for a long time the only FDA-approved medication for pediatrics for obesity, but nobody used it because, one, the effect was very modest, unfortunately, and two, even worse was that the side effects were just unbearable. Nobody would ever stay on it due to the GI adverse effects. So I've probably prescribed it a handful of times in my life early in my career, and I never had anybody be on it for more than a month or two. So they're more for historical purposes. The three that are FDA approved, and we're going to talk about them now in pediatrics, are a combination of phentermine and topiramate, which is marketed as Qsymia. The second one is liraglutide, which is a GLP-1 that's marketed as Saxenda. The third one is semaglutide, and that's kind of the elephant in the room, and I want to spend the most of the time talking about that one. And if it's given for obesity, it's called Wegovy. If it's given for type 2 diabetes, semaglutide is called Ozempic, but it's the same medication. All right, so quickly, phentermine, and this is part of the combination drug that is now FDA approved for kids, so I want to spend a little bit of time talking about it. Phentermine by itself is a very commonly prescribed weight loss medication in adults. Its FDA approval goes down to 17 years old, so it's not FDA approved in kids, but prior to the advent of these three new anti-obesity drugs, we actually did use it a fair amount in kids, and its side effect profile is great. Most people tolerate it very well. It acts as I would say, a cousin of the ADHD meds that we use so frequently in pediatrics. It's a sympathomimetic, so it acts as an appetite suppressant, kind of similar to the ADHD meds. It's inexpensive, it's got a great side effect profile, and in some patients it works really, really well. Not everybody, but in some patients it has a tremendous effect. The problem with phentermine has always been that it's not a long-term solution. So any effect you get is usually there over 6 months, 12 months, 18 months. Everybody's a little bit different, but most patients by at 18 months, 24 months, the effect is going to wear off. And so it's not a long-term solution, unfortunately. So moving on, that we use it a fair amount just because it's cheap and the side effect profile is good. But now we have the advent of now FDA-approved medications for obesity in pediatrics. So I want to kind of take you through how this has come about the last few years. So the first one was liraglutide, which was first FDA approved in adults for type 2 diabetes, then for obesity. And then this New England Journal article came out, I think I'm going to look at it was about 4 or 5 years ago. So liraglutide is a daily GLP-1 injection. And with this study, it was a randomized controlled trial of 251 kids, aged 10 through 17 years old. It was a 56-week duration. We'll look at that duration a little bit closer here in a minute. But here's their primary results. And you can see, I'm looking for my laser here.
The mouse should work too, and that'll work for people in the...
Okay, thank you. So at the 56-week mark, when they took everybody off medication, the liraglutide group had a clear drop in BMI, this is actually here, BMI standard deviation score. But it was about a 10-pound weight loss relative to placebo. And that was highly statistically significant. At 56 weeks, they took everybody off medication and they continued to watch everybody until 82 weeks. And this is one of the major limitations or downsides of the GLP-1s is that once you take patients off them, the weight really does tend to come back. And so you see this major regain in weight, and it probably doesn't take a whole lot of imagination that if you extended this out another 3 months or 6 months, that these lines may not look a whole lot different from each other. And that's unfortunate. That's been seen in the adult world as well as it's been seen in pediatrics. And it kind of is an argument that you have to stay on these medications if you want long-term effect. But while they were on it for that first year, it clearly was effective. And you saw a drop for maybe 16 to 24 weeks or so, and then it kind of plateaued after that. So as I said, it led to about a 10-pound weight loss, 4.5 kilos relative to the placebo group. This was, 2020, this was published in the New England Journal. And that led to, in December 2020, FDA approved liraglutide up to 3 milligrams daily for the treatment of obesity in adolescents aged 12 to 17. And that was big news for us in the obesity world. As I said earlier, unfortunately, it has not led pragmatically to a lot of kids being on these treatments because it still remains very expensive. And for most kids, their insurance has not approved this. It's actually a plan exclusion for most patients. So that's liraglutide. Let's move on now to the next one, phentermine topiramate combo, or Qsymia. So this was an article published in 2022, so just a couple years ago. So they took phentermine, which we talked about a little bit, and then topiramate, which, as you guys know, is a commonly used neurologic drug, both in adults and kids, that's used for headaches, migraine headaches, used for seizures. So we have experience with it in pediatrics. And in the adult world, they've used it as monotherapy in obesity. It has kind of a modest effect. But they combined it with phentermine, and the first trial in adults was published about 12 years ago and led to FDA approval in adults for this medicine, Qsymia. So 2012, it was FDA approved for adults, and led to about a 10% weight loss compared to placebo in the adult world. And it's been studied over now 2 years. I think it's the longest term study they have. And that problem with phentermine I told you about earlier, with it being short-lived effect, that seems to have gone away at least a little bit when you combine it with topiramate. So even at 2 years in the adult world, they see that the effect is sustained. So they did a phase 3 trial in kids, and they did it again over about a 1-year period. In this study, they had 3 study arms. They had a placebo, they had a mid-dose arm, and a high-dose arm of the phentermine topiramate. And here's their primary outcome data. So again, you see a really nice effect. This is the placebo that kind of trends higher over time, as you would expect in pediatrics. The mid-dose got a moderate effect, and the high dose got the most effect. And this actually showed more weight loss than the liraglutide, the daily injection. So this led to FDA approval in June 2022 for Qsymia for weight management in pediatric patients. And that's nice because it's a pill that you take once a day, a pretty good side effect profile. But again, the obstacle here, the limitation, is cost. This is still a very expensive medication, and for most insurance plans, it's a plan exclusion. So this led to the next medication to be approved in the pediatric world, and the most recent is semaglutide. And this is the elephant in the room in terms of its effect. And this is why, as Dr. Hartley mentioned earlier, you see this in the headlines every day. It's true. This has garnered a ton of attention and has really been game-changing in our treatment of obesity. So this New England Journal phase 3 trial came out in late 2022, I believe, and led to FDA approval of semaglutide for adolescents about a year ago. So I want to talk a little bit about semaglutide because I think there's a lot of confusion on this. So semaglutide is the same thing as Ozempic, which is the same thing as Wegovy. The reason they have different names is that the pharmaceutical company, Novo Nordisk, that makes it, they got an FDA approval for type 2 diabetes initially, and they are able to market it when it's given for type 2 diabetes as Ozempic. The next indication came in adults for obesity, and they're able to have a different name when you give it for obesity. So if you are giving semaglutide for the treatment of obesity, it's called Wegovy. If you are giving semaglutide for the treatment of type 2 diabetes, it's called Ozempic, but it's all the same medicine. It's true, there are different, how you administer it, like the pens that they use, the pen needles and stuff, It's a little bit different engineering, and that's part of why they can call it something different. So the actual engineering for how you give it is a little bit different, but the drug itself is the same. So if you get semaglutide from a compounding pharmacy, and it's not brand name, or if you get it from the brand name versions, it's all the same drug. And so this is kind of the timeline for how this has evolved over the last few years in adults, and then finally that last bullet point is the pediatric approval. So we'll talk about the phase 3 trial here next. But any questions, or does that match up with your guys' understanding of kind of the nomenclature of all this? When I hear this talked about in the news or social media, it's almost always they don't really get it right. So I feel like it's there's a lot of confusion behind this still. So the phase 3 trial studied adolescents 12 to 17 years old with obesity. They were randomly assigned in a 2-to-1 ratio to either receive semaglutide up to 2.4 milligrams weekly or placebo. They had 201 patients that underwent randomization. And I think it's important to note that 90% completed treatment. So you hear a lot about the side effects of semaglutide in all the GLP-1s, especially in terms of the adverse side effects. And they are prominent, there's no question about it. But it's a degree of severity. Most people, thankfully, in the trials so far, adults and pediatrics both, are able to tolerate the side effects. And they're usually early in treatment so that they get better over time. And they're not severe enough that it limits them from going up on the dose to the full dose, or in this case, completing this trial. So 90% of the patients in either arm, the medication arm or the placebo arm, they were able to finish the trial. And I think not just finish the trial, but 87% of them got to go to the highest dose on the semaglutide. So there's no question there's a subset of patients that the GI side effects is severe enough that it prevents them from taking it. But the general experience for most people, and this is true in pediatrics too, is that they do have GI side effects, but they're more in the mild category and they're more upfront in the first few weeks of therapy, and they get better with time. So in this trial in pediatrics, the effect of the semaglutide versus placebo was almost 17% difference in BMI. That's a major difference, over 1 year, in far more than the liraglutide, the daily version of the GLP-1 and the Qsymia. So that is really getting into a game-changing degree of effect from a BMI or weight standpoint. And not only is it improving BMI and weight, the cardiometabolic risk factors that they measured improved compared to baseline. So whether it was waist circumference, hemoglobin A1C, cholesterol, liver enzymes, blood pressure, all those improved in the semaglutide group. So it's not just about weight loss, it really is leading to metabolic improvement. So you see here's the figures that looked at their primary data. They did not, so they stopped it at 68 weeks. They only went another 7 weeks. That liraglutide study I showed you, what was it, 16 weeks or maybe even more than that beyond the study point. So you see here, it does start to sharply increase that BMI again once you come off medication. And again, I think if you extend this out another 6 months or so, you're gonna see that really increase. And that's just kind of an unfortunate truth with these medications. You can't just do it for a year and expect the obesity to go away. And I think this is interesting too. This is the percentage of patients that in both groups that achieved certain thresholds of weight loss. And so when you look at more than 20% weight loss compared to baseline, there was 37% in the semaglutide group that achieved that. And that's really starting to get into a range that's similar to bariatric surgery. So that's a remarkable amount of weight loss to achieve.
If it could be paid for, are there people who can take these lives for the rest of their lives?
Well, that's a question we don't, from a scientific evidence-based standpoint, we don't know. Probably, but I think the longest data at this point in the adult world still only goes out 2 years. So there's still this big open question of, is the effect gonna wear off over time? Are there going to be new side effects that develop? You know, we just don't know the answers to those questions. In theory, yes. It's an awfully expensive proposition, and nobody really wants to be on, you know, injection for the rest of your life. But in theory, yes. So I talked a little bit about side effects earlier. That leads to our third and final question. In this trial we're talking about, we'll go over the slide, we'll go over the actual data here in a couple slides, but I'll ask you the question first. What % of patients randomized to semaglutide experienced GI side effects? 22%, 42%, 62%, 82%. And good, well, you guys got it. The right answer is C, 62%. So the placebo arm was 42%. You guys know how often kids complain of stomach pain, right? So, whenever you see those percentages in these phase 3 trials, you always have to kind of think, what was the placebo group? And I've run some of these pharmaceutical trials. If a child over the course of a year gets a strep throat or a stomach bug or something, you have to report that. And whether you think it was related to the medicine or not, you have to report that. So 42% in the placebo group complained of GI adverse effects, 62% in the semaglutide group. I didn't put here contraindications to treating with semaglutide, but really there's not many. I would say pancreatitis, a previous history of pancreatitis, and then medullary thyroid carcinoma is the other one, which is incredibly rare, or a family history of medullary thyroid carcinoma, which is a very rare form of thyroid carcinoma. So most patients don't have contraindications to using semaglutide. So again, kind of just to summarize the medication section, we have new medications that are highly effective. We don't have much access to them at this point in time. What happens with the access over time is anybody's guess. I think most people think that with additional medications available on the market that are coming down the pipeline in the adult world, that's going to put price pressure on these medications. It's going to bring the prices down, and it's going to make it more affordable and more likely for insurance companies to approve it. What the timeline is on that, I have no idea. If we're 1 year away, 5 years away, 10 years away from that. But I think over time that will happen. And I think we collectively as pediatricians will have much better access to these medications eventually, but it's not the reality now. And I don't really see it changing, in the next 12 months or so, but I do think it's going to change eventually. Well, I didn't leave a lot of time for surgery here, so I'm going to go through this pretty quickly. We don't have as good a data for bariatric surgery as we do for medications, but there's two kind of famous publications over the last few years that have come out, both in the New England Journal. Both looked at the same cohort of kids, which was a non-randomized, non-controlled prospective cohort of kids that underwent bariatric surgery. So they had a group of 242, and they published three-year outcomes in 2016, and then they published 5-year outcomes a couple of years ago. So I'll just go through this real quick. The first thing to mention here is that the amount of weight loss relative, well, I'm going to advance a couple more. So the amount of weight loss relative to adults, very similar. Furthermore, the amount of remission that they got from metabolic disorders like type 2 diabetes was outstanding. They had, at the 3-year data, 19 out of 20 kids that had type 2 diabetes at baseline went into remission. So there are some side effects, but we'll save that talk for another time. They're breaking down the walls, so I'm going to finish up here if you've got questions, go ahead and come up to me afterwards. Happy to chat for a few more minutes, but we'll end it here. So thank you guys for your attention. Appreciate it.